about the vertebral basilar junction variation and patellar origin. The first concept that we need to bridge between the cranium and the spinal level are the segmental arrangement, which you will see from animals up to human being, and for sure this area is the junction between the spinal segment and carotid segment. So these the modified carotid drawings that show exactly when during the 5 to 8 millimeter that the fetal start to have the midline fusion of the system here, and then when the neural tissue grow at the area, it start to becoming from the proper segment, becoming some regress and some still growing. And we are involving with the area of the first, second, and third aortic arch level. Finally, at the stage 3, when this internal carotid artery also being starting to develop, we also have this fusion that we call the basilar artery, and there are from some regression of connection to the dorsal aorta. We are now having the longitudinal connection between segmental artery of upper cervical area. So to make this drawing more basic and more understanding, this is a diagram from Pierre's book. We will start with this first, second, and third aortic arch. This one is the ventral aorta, and the upper one is the dorsal aorta. We start from the area of the trigeminal artery, which is shown here, and then the artery, the segmental artery involved is the hypoglossal proatlantal 1, proatlantal 2 over there, and the ventral longitudinal artery is there, seen, and system of this area start with this group of arteries. There are paramedian axis artery that was shown also there. The longitudinal neural artery then now start to fuse, and when they start to fuse at the caudal level, it becomes the anterior spinal artery, and the cephalad level, cranial level, it becomes the basilar artery. So these two arteries are equivalent with just the midline fusion of this pair artery. Why the hypoglossal artery will finally become the ascending pharyngeal system, and the proatlantal 1, proatlantal 2 will becoming the part of the occipital artery later on. So the second concept of the flow change, we start with this concept that the posterior circulation structure rely mostly from the blood supply coming from the anterior circulation. So by that time, there are many connections between anterior and posterior system. And then the posterior fossa structure and occipital will grow, and the posterior circulation become progressively independent from the anterior circulation. Some regression, retardation of many anastomosis. So usually it's left with the peacock. So with the structure of the forming of the lower down system, the flow canal starting to be upward. So the flow change now becoming the two systems becoming mostly separate. The second concept is the metamias and arterial pattern. As you know that each segment of our body have the right and left arterial supply. So usually there are possibility of having this vertical anastomosis between each level, and then this anastomosis will fuse at the midline, and when it fuses, some regression and some persist in the spinal level. The one that persists is probably the radiculomedullary artery which is the concept of the metabolic pattern. So you can see that there could be one dominant and one less dominant segmental artery that contribute to this important midline fusion artery. So what are the roles of segmental arteries? They supply skin, muscles, and bone. They follow and supply peripheral nervous system. It may supply also central nervous system. And in this level of craniovertebral junction, the segmental artery is equivalent to the radiculomedullary artery of posterior fossa. So the function can definitely replace the trunk of vertebral artery and basilar artery, because actually the horizontal segmental artery are the real function segment. So example of this function can be seen mostly in metabolic disease, for example, the spinal arteriovenous metabolic syndrome, the cerebrofacial arteriovenous metabolic syndrome, previously called Cobb syndrome at the spinal level. To see clearly at the craniovertebral junction, if we talk about the area of the skin, subcutaneous soft tissue malformation and intradural malformation, it can be within the same metabolic lesion. For example, this is SAMS 1 that we count the level here 1, and it's combined pharyngo-occipital supplied to the malformation as well as the segmental arterial supply to the intradural malformation. Let's just clear about which part is real segmental artery. As we know that in embryology, all the segmental arteries are equally important, but later on there are more good intersegmental anastomosis that finally become vertebral artery. So the real segmental artery regress, left with only one prominent, which is the horizontal part at C1 segment of the vertebral artery. So this is probably the real segmental artery that is still seen in adult. The rest can be very small that we see now as so-called branching from vertebral, but in the opposite. They exist before and then the intersegmental connection develop, so-called vertebral artery. In the upper thoracic level, it's the same concept. When you talk about the upper thoracic level, and there are intersegmental connection artery that we call supreme intercostal artery, okay? And lowermost at the lateral sacral artery can be the intersegmental connection of the lower sacral segmental artery. So not only that figure, but we have other spinal cephalic homologue, especially perforators. If we know that ventral system give rise to the dominant perforators, that is called, for example, in the spinal level, the sulcocommisural artery coming off from the ventral spinal artery. And the dorsal system are mostly circumferential and give, from outside the perforator supply to the more cortical part of the system, same as the craniovertebral junction, that you have the system in the ventral that supply the more dominant perforators, and then some of the circumferential perforators are coming off dorsally. So the pattern are the same between this craniovertebral junction and the spinal level. So nice picture that Philip will show quite a lot is the ventral piercing through the ventral sulcus, the perforator system, important one, the ventral system. So for saying this, if we count that there are spinal approximately 31 segments and to the head and neck region, in the head and neck region we count between C4, C3, C2, C1 segmental artery, especially C1 the nerve regress, and then and we go up to the hypoglossal, which is related to cranial 19 part of 11-12, and then the otic, which is not going out of the cranial cavity, and we end up at the trigeminal level. So can make a very nice, simple diagram that I highly recommend you to trying to understand this area of variation by writing down the possibility of the segmental arrangement of the artery that is fed from C4, C3, C2, C1. C1 and C2 is the pro-atlantal 1, pro-atlantal 2, hypoglossal, otic, and trigeminal. And as I talked to you that there are kind of the pyramidal axis. And then the equivalent of trigeminal later on will be the internal carotid and basilar anastomosis. The otic will for sure be ICA. And the hypoglossal is a system of ascending pharyngeal and pica. While the pro-atlantal 1 and pro-atlantal 2 is the occipital vertebral system. And C3, C4 for sure is ascending cervical and vertebral system. And then you draw the midline, which either in the cephalic basilar artery, and quarter 1 is the ventral spinal artery. You could draw the dura, which is there, and now you start to see the very classic type of the artery of the region, which is very symmetrical. Balance between right and left. And then you see variation. The variation is that the role to see the variation is pick up the artery that you surely know. For this one, you know this is the vertebral artery. You know that it's pica probably. And then later on, you see that it's not the usual vertebral artery at cervical segment. There is another smaller artery, and this can be explained by the flow from the C2, C3 inflow into the system and give rise to pica and give rise to also the basilar artery, vertebral basilar artery upstream. So you can call many names, for example, C3 origin of the pica, or the ascending cervical origin of vertebral artery. So in nominate the variation, there can be more than one names. Yes?
I cannot see your cursor. Do you show?
Okay, sorry. Thank you. So, sorry. I recommend you to recognize the artery that you know best. This is vertebral artery and this is a pica. So you see a strange artery and constitute to this. My drawing into the diagram up here is, for example, this one. So usually when you have the dominant flow from one of these anatomical channels to fill up the system, the usual normal system will become smaller or regress. Same as this. If you see that, how come you see vertebral artery from the C3, C4 segment there and not lower down and you see this artery? So it's the same explanation that you have the more dominant flow into the C3, C2 segment and fill up the system over there. Again, in this variation, you know that at least the segment here is the usual vertebral artery. You see the pica, and there are two channels here. So the usual one should be this one, and now you have more dominant flow there. So probably you can try to understand better by drawing that C4 segment here of vertebral artery. You have dominant flow into the system and give rise to this why the usual one is a small hyperplasia. We start to talk about the first system, the first artery, which is the pro-atlantal 1 and pro-atlantal 2. I remind you that it comes from here, and the connection is probably highly related to the intersegmental artery that becoming the vertebral artery already. So this is not so surprised that when you inject vertebral artery, inject vertebral artery, you have very often see occipital artery coming off. Because in the embryo it comes together, so sometimes this is C1 and C2 and proaglantal 1 and proaglantal 2 origin of this occipital artery. So they can use both systems here, C1 or lower down the C2 channel to contribute. So the name could be bilateral vertebral origin of occipital artery at C1 and C2. The channel of the proaglantal can be persistent and big. So this is the big proaglantal 1 system, and this proaglantal 1 can be seen as the basilar system originate from internal carotid artery, cervical segment, joined via the C1 space. This can be the description of the evaluation, and also you can describe also the occipital artery origin. So that is not so surprised that the catheter is superselective in each system, either the vertebral system or this occipital, but you can finally feel the two systems together because it's linked via the C1 and C2 space to fill up all of this artery. And diaphragm can be because you have more dominant flow via the C1 space, so that it can fill up all the system. The C2 can be seen either through the regular channel at C2, or can use also the kind of muscular branches around and becoming, for example, this is pharyngeal occipital injection. You see that at the C2 level, you fill up the vertebral artery. This one is also that you can see at C2 level, you fill up vertebral artery. So this channel can be persist and it can be of use in describing all these. For example, this can be described as C2 vertebral origin of occipital artery, for example. Another example that we inject external carotid artery, and the occipital artery was seen at the C1, C2 channel together, filling up vertebral basilar system. So it's the same description that C1 and C2 channel will use in this variation. So the description above is can be described. When the channel seems to be C1, it comes down to C2 before it fills up the system of the vertebral artery. So this is probably the drawing that can be seen like this, when you see dominant flow at the C2 system, which finally see the pica supply there and some flow visualized into the vertebral basilar system. In the clinical use, you know that when you have some kind of this high flow lesion at the C1 segment of the vertebral artery, you remember horizontal part of C1 segment of vertebral artery is the real segmental artery that persists, and then AP and lateral. So for sure you know that the artery of the region that you need to inject is pharyngeal occipital system. So in the occipital system, you know that there are C1 and C2 visualization to fill up the fistula. By doing the injection of all the possibility of having this connection of the sumping high flow lesion to see all the connection at two levels, make you better see where is the real fistula and how to close the fistula completely. Another example that we inject, this picture is to inject external, so-called external carotid artery. And the latter one is so-called inject vertebral artery in the same patient. You know that there are a lot of variation here in the front to see around what is described for the system that contribute into internal carotid branch. But you will see that at C2 segment, you have this artery filling up vertebral artery. Same in the vertebral artery injection, you see nicely this pharyngeal branch of ascending pharyngeal. So to see this in your annual, your regular practice is to make you understand that there could be this kind of variation. Simple injection, again, C1, C2, C3, that you can have this origin of, the occipital branch, and you can see again in the pharyngeal occipital injection, you see that it's come down from the occipital at the C2 level, filling up vertebral artery at that level. Nice picture from the cervical nerve that show that also at the C2 level you can catch up with this, filling into the vertebral artery while you inject this ascending cervical artery, filling and using the same channel of C2. We were having this clinical example of the VV fistula already becoming slow flow. We were having this example, so we try to see whether we're going to close up the rest of the fistula. Seeing that there is another artery coming off there, if we were able to close the fistula with preservation of this, it worked that this system still filling up down to the cervical artery and filling up to give help to the vertebral basilar supply. So now we move from occipital artery to the hypoglossal. The hypoglossal, as I told you, it's become the system of ascending pharyngeal. Ascending pharyngeal is very small artery, but it's very important artery because it's the only artery that supply the alimentary or GI system and supply the neuromeningeal trunk. No other arteries making this function. So we know that we have, 2, 3 pharyngeal branches, and then we have musculospinal branch, which usually supply whatever tumors around the head and neck area, and we have the neuromeningeal trunk there. So this hypoglossal can be small as regular one or big and persist with the flow coming off from connection to the carotid system. So by drawing that, you know that if you have higher flow persist with the hypoglossal system, this can be a draw like that, and the usual system will be smaller. And seeing this example, the pharyngeal brush and then at the neuromeningeal trunk and also anasomos to give rise to this pica, and the regular vertebral injection also give rise to pica, so it's bidirectional supply to the pica from both system. This is very important diagram that you can find in the surgical neuroangiography book. It explains all the possibility of anastomosis between the pharyngeal occipital system and vertebral artery. So the very important landmark is the C3 segment. And you know this is the pharyngeal branch, and this is the hypoglossal branch that go through the hypoglossal canal, and you know that at the C3 level, it hooks into the vertebral artery. While in the occipital artery level, you have this cervical artery hook also into the same level, approximately C3 level, as well as the ascending cervical. So there are many examples to describe this, and it really helps when you need to embolize things and you really concerned about the connection. This is regular injection. You see occipital artery give some tiny little branch and filling down at this level. So there's no surprise that you will finally fill up the vertebral system at that level, and when you inject vertebral artery, it shows exactly the same route of connection that you will probably see that this tiny little tweak is the basilar, is the vertebral artery. Okay? The same road, it's there. It's there. So the real clinical usage is now you are dealing with the glomus tympanicum and you are requested to do embolization, and you hook into super selectively embolize, and you need to know that this is after embolize. You know that there are remaining branches coming down to hook into the level of C2, C3, filling up vertebral artery. If you don't see before treatment, you didn't realize that it's there. It's just likely to proximal to force injection by any embolic material too much, and you know that this could happen that you have posterior circulation stroke. Let me introduce you to another interesting arterial system. I think we mentioned a little bit yesterday what is odontoid arterial system. Let's make sure that you understand that this artery is extradural arterial artery. So that means the function is to supply something extradural. Okay? So this is the shape overlying the dens or odontoid arch. So it comprises of the descending branch of the hypoglossal artery, anastomosis, vertebral artery, at C3. Everything happened at C3 segment. Okay, so it's maybe not seeing the complete system of bilateral and like this is diagram. So this all the clival artery, and this is what we see. What we see is that this is partly in the lateral view, the odontoid arch system. Okay, so let's go to the clinical practice. If you super selective injection of this, for example, the carotid tip is hypoglossal division, you may see the entire system and cross over to contralateral ascending pharyngeal system too, while you may feel like finally bilateral vertebral artery. Okay, in the real practice, you see very tiny little arterial arch system. This is glomus at the head neck region, and you still feel up to contralateral artery. The roles of this extradural is, I told you, example of meningioma. So you know meningioma at the region can be supplied by the branch here of the ascending pharyngeal, and also if you inject well, this is part of the right side odontoid arch artery. It connects to the supply from the ascending pharyngeal. So you see that this is example of the contribution of the odontoid arch system to extradural lesion. Another extradural lesion, for example, the plaque and glioma of the region, you may again see the half, the right side ipsilateral odontoid arch arterial system enlarged, and we are take part of supplying the extradural lesion. This foramen magnum area, dural fistula, you may see that another contribution from the left side ipsilateral odontoid arch system that also contribute in supplying this dural shunt. Condylar dural shunt, you for sure inject the pharyngo-occipital system, and you need to also know that to inject vertebral artery will give you some clues that this odontoid arch system always participate in as a feeders to the lesion at the condylar system. Another condylar dural shunt always, not only the ascending pharyngeal injection, but try to see how these odontoid arch participate. You may have a chance to choose as one of the route to embolize or not. To review the arterial supply around the foramen magnum, you know that it depends on which side of the foramen magnum, but usually I told you that there are contribution from the clival branch, the hypoglossal branch, the jugular branch area that supply most of the area of the foramen magnum. So don't forget that mostly at anterior lip, upper branch of the odontoid arch also take part of the supply. We have these, myelopathy and abnormal blood vessels, and we know that this finally prove that there is a shunt at the left side around the foramen magnum level for sure. The artery that you will need to inject, this is superselective injection of acetylpharyngeal. You see more clearly where is the shunt located, rather than confusing with the injection just the vertebral arteries. So now you have no choice if you need to go for embolization. Acetylpharyngeal is not connected very frequently to the vertebral artery, but you know that anastomosis a lot acute. They have many routes to anastomosis with internal carotid artery. You know that mostly the pharyngeal branch, the superior pharyngeal branch, have more into the thoracovaginal and have the connection to the internal carotid system. And not only that, they are the clival system that can recruit all the branch to contribute also to the internal carotid system. So having that, all the possibility of the connection makes you understand that we may divide it into the three group, the cavernous group, the Peters group, and the clival group that can have the connection between the ascending pharyngeal and the internal carotid artery. And this is all the three main group of the final arteries that can make the connection between ascending pharyngeal and internal carotid artery. This is what you inject the superior pharyngeal branch, thoracovaginal, and go back into anastomose with the internal carotid artery. And it's the same artery that you can see here. Mostly this is mandibular artery connection to the internal carotid artery. In superselective injection, again, not only the filling down at the C3 level for vertebral artery, you see also at the superior pharyngeal branch going back through the mandibular, filling up all this internal carotid artery. So this is the dangerous artery that can not only making the stroke at the posterior circulation, but also anterior circulation. So this is the regular musculospinal supply to the glomus tumor. It also contributes into the meningeal of the region. The posterior meningeal artery can come from the jugular division of the ascending pharyngeal, and it has a very typical straight along the dura. And in AP, quite unique to see the straight oblique artery over there. And as you know, that it can also come from the vertebral artery or the pica, also for the meningeal branch. Now we move a little bit to one of the most important artery of the region. It is pica. So there are a lot of variation of pica that you can see. But for example, this variation, what is the variation can be drawn. There is the pica coming off very proximal, extradural origin of the big pica over there. So your decision to treat this dissecting aneurysm can be considered if you evaluate all of these. For example, this one is called C1 extradural origin of pica. Again, in our real practice, the possibility of treating the best treatment for dissecting aneurysm is to sacrifice it. You can go to sacrifice that, leaving the ipsilateral vertebral with supplying this extradural pica still there, but no need. If the contralateral system is enough, you can do this treatment. Not only the C1 pica, but it can come down to C2 level. Look at this. This is origin of the pica. So it is coming off from here to here. So this is the origin of the pica on this side. And so seeing that this is the origin of the pica, that we see that coming off here, and in this special case give rise to bihemispheric supply. So we know that this is a variation of the pica. Not only that, you can see a duplication of the superior cerebellar bilateral duplication of the pica bilateral on the right side, and this is the junction of right and left supply from this pica. And when you inject one side and you don't see pica at all, you can be sure that the contralateral vertebral injection will for sure give rise to bilateral staining of the pica system. What is this hole? This hole is just, persistent of the channel that exists there and can be a drawing in the diagram like this. And it can be even bilateral. This one, it extends down to the C2 level for the hole, and on the right side is only at this C1, C2. This is coming down to C3 level. So what do you call this variation? Is one hole and two hole. So this one is called the duplication of the vertebral artery at C1, C2. This one you can call the double origin of the pica. We're going to talk about this multiple channel in the vessels at the end of this talk. So what can be of help in clinical practice if you have more than one origin of pica? In some cases, that for sure this extradural pica give rise to the meningeal system and some to the cerebellar hemisphere, while the intradural pica supply medullary and vermian segment. So in case something happened to one, you still have another supply to the rest. This is what can be applied to the clinical practice. So we were having this massive subarachnoid hemorrhage, and we don't see much the pica, especially lower down. We see the irregular artery here that probably be the cause of this subarachnoid hemorrhage. So we're sure that with this, the dissection could be the process that involved in the pica origin. And for sure, if you go for the MRI, you can see not only the subarachnoid hemorrhage, you will see this kind of effect of the pica infarction from the process. And to explain this mode again, the double origin of pica is just the persisting channel there. While the whole lower down that you can see the duplication of vertebral artery is just the remnant of the channels as a flow persists, which is a variation. So again, we have the clinical example of this nice clinical usage that you have one extra C2 level extradural origin of pica, while you have also the regular pica. And if you need to treat by sacrifice in this disease, you may see that to sacrifice above, you still have the lower down pica origin still supply some of the pica territory, so the infarction will not be the entire system infarct, but only some segmental that can be better than not having the two origin. One of the most frequent variation that we see in the region is Pica. And that means this regress and the dominant Ica give rise to this Pica. So this is very often in our real practice, and you see that this Ica give big Pica branch downstream. Some importance of the variation around this area, we have this tiny little ruptured aneurysm of the proximal Pica origin. You need to really check what is this Pica function. So this is the left Pica is probably take charge of most of the supply, while the right Pica is kind of variation. So the treatment is for sure make sure that you preserve whatever the system, even it's quite some challenge to just not putting, not sacrificing, because most of this aneurysm is dissecting in terms of nature. But if you have chance to follow up, I choose to just do something minimal and follow up. Fortunately, it's already 2 years and it's no recurrence. Again, this very long loop of Pica can be seen. This is a very long loop of Pica. And another interesting, we have this subarachnoid hemorrhage. And the only finding that is here, for sure, is ruptured dissecting aneurysm at the origin of Pica. I was discussing a lot about the risk of treatment, and then the patient was clinically good, so he asked to wait for a week. So we bring him back, planning for treatment. Look what happened. So, the healing process of dissection that you may hear later on in the day is that it may heal in different way. Healing process can be obliteration, occlusion. The healing process can be nicely same luminal, or it can be narrow lumen. So this one is the closing up the artery here, but the Ica immediately give the collateral to supply the Pica. So there are many reports of this possibility of connection, anastomosis in between the Ica and Pica at that level. Luckily, so we don't really take risk of any treatment. It doesn't mean that you wait, so this is example of the case. Yeah, and Pica is nicely seen by that example. Again, how about Pica? It's the same. That means Pica take charge to give supply to the Ica territory. So the drawing will be this Pica and some regression of the usual Ica. So that means now we come to the importance. Why do we talk a lot about origin of Pica? Because simply try to look what Pierre explained. We know that the system, the ventral system, give perforators, important ventral perforators, while the dorsal system usually give, circumferential type of lateral. And this equivalent between spinal and cranial vertebral junction, the vertebral artery, the ventral system, and the Pica is a kind of give rise to this circumferential. If the origin of Pica is more lateral, the function would be more to the dorsal perforators. But if the Pica coming off here, more medial, close, they have the possibility of supply the ventral perforators. Okay, so that is the row. Go back again. If you go back again to see the usual and more medial location. So this easily explain that usually if you have, far away from midline, the origin of pica. Usually it's relatively safe for the ventral perforators unless it's unfortunately becoming bioministric or you do very aggressive embolization. So let's start to see. Okay, so in double origin of pica, this is double origin of pica. This is the one close to midline. So they have chance to give perforators, while this arm is relatively far from midline. You understand? So there is less chance to give perforators. Okay? And so also variation of pica. So because pica now is far away from midline, so you have less chance for that pica to give perforators. And in the opposite, in this situation, the segment of vertebral artery will be the one responsible for giving the ventral perforators because it's more close to the midline. Okay, if we will explain because this is his work published years ago. And extradural. Now you have C1 extradural pica. So now it's far away from midline. Again, the vertebral artery will be the one who takes charge of the ventral perforators. Okay? So I'm sure that it's going to show the real anatomy in the dissecting specimen. So the lateral spinal artery will be shown later on, but just focus about the perforators. So the usual one is the one closing, the one is close to the midline, the regular pica will be for sure still supplying the ventral perforators. We have some words about the lateral spinal artery. So what is lateral spinal artery? I introduce you another interesting artery that is sexually located ventral to posterior nerve root from the upstream, and then at C4-5 level it becoming located dorsally. So it functions as the dorsal system of the upper cervical structure. For example, this drawing, there could be two possibility of origin of lateral spinal artery if you have extradural origin of pica. Lateral spinal artery will come off from this extradural pica. If you have the regular intradural pica, lateral spinal artery will come off from vertebral artery. Okay? And you sure that this is dorsal system of the upper cervical level, so when it comes down to C4, 5, 6, it will probably merge with the posterior spinal arterial system of the spinal cord. Okay? So I show you some example. This is have the small intradural pica here. So these lateral spinal artery will contribute to supply the AVMs of the region as seen coming off from the vertebral artery. Why in this example that we have C1 extradural pica? So for sure this lateral spinal artery arises from this extradural pica. Okay? Another example, I have this, lesion at, arteriovenous malformation. So we were seeing that, okay, we have this kind of C1 level extradural pica, and we have this big artery coming off at the left dorsal. If you look carefully, From the origin of the extradural pica, we have origin of this artery. So in the example, the lateral spinal artery that finally feed these aliens arising from this pica. And for sure, to prove that it's the same system, we inject after embolize, being able to embolize this, we check the intercostal, the supreme intercostal at the upper thoracic level, and we see this posterior or dorsal spinal artery hook with the system coming down, and this is a remnant of the previous embolization. We were able to get rid of the malformation. So the system becoming the same system to make sure that you understand that the anatomy are there. So by knowing that, you know that at least there are two possible ways to go up into hook. I remember that I for sure didn't choose the lateral spinal artery to hook, so I chose the lower segment, hook into this and embolize. So there will be some words about, again, the pica is very important. We now talking about ventral perforators, we are talking about the origin of lateral spinal artery, and now we are talking about the relation with the anterior spinal artery origin. In the symmetrical pica, you can have a two symmetrical anterior spinal artery. Okay? In the case of asymmetrical pica, the nearest side pica can be the origin of the anterior spinal artery. So if you have extradural pica, look for contralateral pica or ica pica. The nearest is the side of anterior spinal artery. So for sure you don't see anything from here, and you inject the pica system easier, so for sure you can expect the anterior spinal artery coming off from the nearest pica side, not contralateral side. And again, this is the origin of the anterior spinal artery, and there is no visible pica here. The pica is there. So this will be shown in the real specimen of it a lot. So one of the last items that I want to state here is that when we see more than one lumen, so I think it's nicely summarized. I think Timo did in a few years ago with this summary as we were confused. So the very first is embryology. If you have a lack of fusion of embryologically paired vessel leading to segmental unfused arteries, this is the first type of two lumens. So let's go to the example. So it will be seen mostly in the midline artery, for example, basilar artery, which we expect complete fusion. But if there is a segment of unfused, you call this whole vertebral, focal, unfused, incomplete, fused, whatever, rather than fenestration. Because to call fenestration is a little bit confused. To understand together, it can be described. The fenestration for me is like describe a shape. But if you want to describe the cause, you better call this is segmental unfused of the basilar or anterior spinal artery midline. So this can be seen in most of the midline, including the anterior cerebral artery at the area of the midline that have the holes. So the concept of this unfused segment, let's go back to this vertical anastomosis between each segmental artery that can fuse in the midline. But what happens if there is a focal unfused segment? The important is also not only the shape, but each arm provided the ventral perforators. So that means if you are destroying by chance one of the arm, you have hemichord or hemi-side problem rather than the transection or bilateral symptoms, because each arm gives rise to each ventral side perforators. Okay, so this is the importance of this one. Number two, what we call duplication. Duplication is due to two embryologically different vessels. No? The first one is the same trunk, but this one is a different vessel. Remember the diagram that I draw to you, and there are a lot of channels that can be persist and can be shown later on. This is called duplication because it is the persistence of the previously seen channels that was nicely hold up there to here. So this is number two explanation. Again, you can call double origin, but actually it's a kind of the duplication of the artery here, which persists the channel. Okay, number three, we prove that there are some special location that it probably the two holes, the holes are from the extracerebral anastomosis between perforators, can lead to the aspect of double lumen in a single artery. So can be encountered both close to anterior and posterior perforating substance established from the embryologically persist in the previous time, the radii of the perforator. So, for example, Pierre put this diagram, this angiogram correlated with Phillips specimen that this is possibility related to cause pseudo P1 duplication, which is actually the large extracerebral perforators anastomosis, and it can also be seen in the M1 area also. And probably the so-called through fenestration, it should be applied to a single artery with two luminal channels. And this can be, for example, during development, there is a nearby nerve or anatomical structure piercing through the artery during development and typically encountered in the vertebral artery or ICA at the neck. Okay, so the classic one that was put in the book is something in the cervical in carotid. Like this, probably is a true fenestration, and probably here a hole, here a hole. So at least it's probably not fully explanation of every single one, but at least we managed to separate into 4 groups. What are the importance of, for example, midline non-fused segment? Because the wall is not complete by then. It's not like the histopathological section is the tunica media of medial wall progressively thinning. This continuity of elastin at the proximal end of the fenestration. So for sure, you can look at this kind of shape of fenestration, which actually is the segmental unfused of this artery, and you can find this aneurysm as the weak point, and usually it occurs at the base, the proximal limb of the non-fusion segment is not hanging down from the upper limb. So go back to your aneurysm at the location, and you can now see that it's classically be seen like that. We were having also the clinical application. We were having this aneurysm treatment. The coil was pushed there. We're going to put the web inside, and by passing through this small channel, which probably a little bigger, because if you want to put something like web, you probably need to put 2 microcatheter system and this and that. So maybe by doing that through one of the limb, you may create the possibility of having the perforators in function, because this is, you see that is, interrupt with a small side, a small limb, and this can occur during the procedure. So take a look and try to probably go back and use something that is not too big system to use. For example, this one, they put the 6 frame up a little bit high. Last thing before we finish is The unfused segment is clearly seen more in the spinal segment. You can see this is a long unfused segment of the ventral spinal artery. So as I told you, the wrist is again another example of long unfused segment of the system. So at least you know this is a classic case that Jacques Young and Pierre put many years ago, that the worst extreme example is that you have the separate, unfused, totally unfused segment of the basilar trunk. This is super rare, but it's classic to have a look at. Thank you. And this was Pierre in 1993. Thank you.